talking about preterm labor, but okay, suppose preterm labor happens. What is the problem with preterm labor? Why are we talking so much about preterm labor? The problem with preterm labor, there are two problems. Number one, the lungs of the fetus are not mature, right? So when a patient goes into preterm labor, the lungs are not mature. It is said that the lungs of the fetus, they start maturing by 34 weeks and they are matured by 37 weeks, right? So whenever preterm labor happens, the lungs of the fetus are not mature. That is one problem. The second problem is that the brain of the fetus is not mature. What do you mean by this? That means there are increased chances of cerebral palsy, right? So these are the two problems which can happen when a patient goes into preterm labor. Now, again, as I told you, it is not only important to diagnose preterm labor. Is there any method by which we can treat these problems? Yes. For lung maturity, we have corticosteroids. Right? So whenever a patient goes into preterm labor, because the lungs of the baby are not mature, you can give them corticosteroids. I will be talking to you in detail about corticosteroids, when to give corticosteroids and when not to give, but understand the basic principle. And is there any drug which can decrease the chances of cerebral palsy? Yes. Magnesium sulfate. Magnesium sulfate is given in preterm labor to decrease the chances of cerebral palsy, in other words, for neuroprotection, right? So now let us talk in detail about corticosteroids and about, magnesium sulfate. So talking about corticosteroids, what is the role of corticosteroids in preterm labor? The role of corticosteroids in preterm labor is, number one, it accelerates the lung maturity. It accelerates the formation of surfactant and release of surfactant. And because it accelerates the formation of surfactant and release of surfactant, there will be decreased chances of respiratory distress syndrome and there will be decreased chances of transient tachypnea of the newborn, right? Number two, it brings about vascular stability. Now, because it brings about vascular stability, it decreases the chances of intraventricular hemorrhage and it decreases the chances of necrotizing enterocolitis, right? So these are the advantages of using corticosteroids. Now, what are the indications for using corticosteroid? Number one, the definitive indication for using corticosteroid is whenever preterm labor happens at less than 34 weeks. So whenever preterm labor is happening at less than 34 weeks, as I told you, the lungs of the fetus, they start maturing by 34 weeks. So if preterm labor is happening at less than 34 weeks, definitely you have to give corticosteroids. Now, suppose if preterm labor is happening between 34 weeks to 36 weeks plus 6 days, right? Then there are various different guidelines. Some guidelines say that you have to give corticosteroid in this period. Some guidelines says that you don't have to give corticosteroids in this period. But what we have to follow is the ACOG guidelines. What are ACOG guidelines saying? ACOG guidelines, that is American College of Obstetrician and Gynecologist, they say that if preterm labor is happening between 34 weeks to 36 weeks plus 6 days, you should be giving corticosteroid, right? So even though in your colleges, you might be seeing that if a patient is coming in preterm labor between 34 to 36 weeks plus 6 days, the hospital, the gynecologists, the obstetricians, the professors in your college, they are not giving corticosteroid. But you have to answer as per the guidelines, as per ACOG guidelines. And ACOG guidelines say that even if preterm labor is happening between 34 to 36 weeks plus 6 days, you have to give corticosteroids, but with the following caveats. What are the caveats? The caveats are, number one, patient should not be having chorioamnionitis, because chorioamnionitis is an absolute contraindication for giving corticosteroids at any gestational age, right? So your patient should not be having chorioamnionitis, number one. Number two, patient should not have been given dose of corticosteroid earlier. Now, what do you mean by this? This means, suppose you have a patient who had a preterm labor at 30 weeks, right? Now, at 30 weeks, you gave her corticosteroids, and at that time, her, after keeping her for 8 to 10 hours, you saw that the contractions have subsided. You completed the course of corticosteroid and you have sent the patient back home. Right? Now, this patient, after this, she didn't come to you. She didn't have any problems. But now, again, at 35 weeks, she's experiencing contractions. She's having preterm labor. Now, in this category of patient, because she was given corticosteroid earlier, I am not going to give corticosteroid. Right? So ACOG says that you are going to give corticosteroid between 34 to 36 weeks plus 6 days only if earlier she was not given a course of corticosteroid. And third caveat is that whenever you give corticosteroid to a patient at this gestational age, you should monitor their neonates. Once delivery happens, you should monitor their neonates for hypoglycemia. Right? So once the baby is born, you should monitor them for hypoglycemia. Right? So one indication for giving corticosteroid was if preterm labor happens at less than 34 weeks. Second indication for giving corticosteroid is when preterm labor is happening between 34 to 36 weeks plus 6 days. And the third indication for giving corticosteroid, which all of you will have to remember, that is again a relatively new update, that is if cesarean section is being done for any reason. If cesarean section is being done for any reason at less than 37 weeks. So for any reason, if you are doing cesarean section at less than 37 weeks, you have to give corticosteroids. Is that clear to all of you? Yes. So these are the indications for giving corticosteroid. Now, when you are giving corticosteroid, please remember that the action of corticosteroid, it begins immediately. Right? The moment you give the first dose of corticosteroid, the action is going to begin immediately. But best result will be seen after 48 hours of the first dose. Right? So maximum efficacy, when we say, it is seen between 2 to 7 days. Once you've given corticosteroid injection, then between 2 to 7 days is the maximum efficacy of corticosteroid. So for best results, you should wait for 48 hours. Right? Now, based on this, we have a few guidelines. The guidelines say that suppose if you are giving corticosteroid injection in preterm labor, which is happening at less than 34 weeks. Right? So preterm labor, which is happening at less than 34 weeks, when you are giving corticosteroid, now this is the time when the lungs haven't matured at all. Right? So I want corticosteroids to have to reach their maximum efficacy. That means in such patients, I need to wait for 48 hours. I don't want them to deliver, after giving corticosteroid injections, I want them to have at least a waiting period of 48 hours before they can deliver, right? That is why, so in order to buy time for them, in such category of patients, I am going to use tocolytics for 48 hours. Are you understanding that if preterm labor is happening at less than 34 weeks, right? Less than equal to 34 weeks. What am I going to do? In such category of patients, I want to buy time for the corticosteroids to act. And the maximum efficacy of corticosteroid is seen after 48 hours. So in this category of patient, I don't want them to deliver for 48 hours after I've given the first dose of corticosteroid. So in this category of patients, so that I get time, I can buy time, I'm going to give them tocolytics. And common sense tells me, for how much time am I going to give them tocolytics? For 48 hours, right? But if you are giving corticosteroid in a patient of preterm labor between 34 weeks to 36 weeks plus 6 days. Now, in this category of patient, as I told you that the lungs of the fetus, they start maturing by themselves by this time. Right, so in this category of patient, I am going to give them corticosteroid without tocolytics. Because by chance, even before, if they deliver, before the complete course of corticosteroid is over, right, still I am not worried, because even in this category of females, because the lungs of the baby already start maturing by this time. So in this category of patients, you are going to give them corticosteroid, but you are not going to give them tocolytics, right? For just in case, even if they deliver after giving even one injection of corticosteroid, I won't be worried, because already the lungs of the babies start maturing by this time. But then if you are giving corticosteroid to a patient who is at less than 34 weeks and gone into preterm labor, then along with corticosteroid, you are going to use tocolytics. Is that clear to all of you? When to use tocolytics with corticosteroid and when not to use? Okay. Now, what are the side effects of corticosteroid? As you all know, with any steroid injection, whenever you give steroids, it is going to lead to increase in blood sugar levels. So in mother, you are going to get hyperglycemia. And what is the clinical importance of this statement? The clinical importance is that suppose I have to screen a female for gestational diabetes. Right? All of you know that screening for gestational diabetes, it should be done between 24 to 26 weeks. In India, again, we follow the DIPSI criteria where we do screening twice. One is when a female comes to you for the first antenatal visits, and second is when between 24 to 26 weeks. So suppose there is a pregnant female in whom you had planned a screening for gestational diabetes at 26 weeks. At 26 weeks, she didn't come to you. She comes to you at 28 weeks and she has gone into preterm labor at that time, right? Now, in this category of patient, I am going to give corticosteroid, right? So that the lungs of the baby mature. But then when am I going to do screening for gestational diabetes? So because corticosteroid can increase the blood sugar levels, that is why I have to keep in mind that either screening for gestational diabetes should be done before giving the corticosteroid injection, before giving steroid injection, or it should be done 5 days after giving the steroid injection. Right? That is one thing which you have to keep in mind. Second thing you have to keep in mind is you have to monitor the glucose levels in the mother. Whenever you give steroids, please monitor the glucose levels in mother. And what does ACOG says? ACOG says if you are giving corticosteroid between 34 weeks to 36 weeks plus 6 days, then you also have to monitor the neonate's glucose levels once the neonate is born, right? Okay. What is the dose of corticosteroid? The dose of corticosteroid, see, there are two corticosteroids which you can give for lung maturity. One of them is betamethasone and the other is dexamethasone. Why are we using only these two? Because these two can cross the placenta and they can act to bring about fetal lung maturity. Those steroids which cannot cross the placenta, for example, hydrocortisone, prednisolone, they cannot be used for bringing about fetal lung maturity. Now, the dose of betamethasone is you have to give 2 injections of betamethasone, 12 mg each, 24 hours apart, right? Intramuscularly. Now, betamethasone is the steroid which is preferred worldwide to bring about fetal lung maturity. In India, we use the cheaper alternative, and that is dexamethasone. Dexamethasone, you have to give 4 injections, 6 mg each, 12 hourly, and again you have to give it intramuscularly. Both these doses are very, very important and they have been asked in various exams. Right? The absolute contraindication for giving corticosteroid injection is chorioamnionitis. Chorioamnionitis. Please note that diabetes and hypertension, they are not a contraindication for steroids. Right? There is only one contraindication, and that is chorioamnionitis. Although corticosteroids are increasing blood sugar, but then that doesn't mean in diabetic female we are not going to give corticosteroids if they go into preterm labor. The only thing what you will have to do is you will have to monitor their glucose levels, right? Then repeat corticosteroid injections should not be given because it can lead to cerebral palsy. So earlier when I was doing my residency, the protocol was that if you have given corticosteroid injection and the patient doesn't deliver after giving corticosteroid, then every weekly we used to repeat the corticosteroid injection till the time the patient attains 37 weeks, right? But then studies were done and they showed that if you give repeated corticosteroid injections, then it leads to cerebral palsy. And that is why now we have to give only one course of corticosteroid. Clear to all of you? Yes. Now, coming to another important thing, and that is tocolytics. So what is the role of tocolytics in preterm labor? The only role of tocolytics in preterm labor is to buy time for corticosteroids to act. Right? That is the only rule. Right? Maximum you have to give tocolytics up till 34 weeks of pregnancy. Please remember, tocolytics are not given at more than 34 weeks, right? So they are never given at more than 34 weeks and they are never given for more than 48 hours. Always you have to give tocolytics when patient goes into preterm labor at less than 34 weeks and you have to give it maximum up till 48 hours. Never are you going to give it for more than 48 hours. Right? If I ask you what are the first line tocolytics, there are two first line tocolytics. Number one, indomethacin, and number two, nifedipine. In India, the tocolytic of choice is nifedipine. Right? In India, the tocolytic of choice is nifedipine, but international guidelines are different. According to ACOG, up till 32 weeks, the tocolytic of choice is nifedipine. Between 32 to 34 weeks, up till 32 weeks, the tocolytic of choice is endomethacin. Between 32 to 34 weeks, the tocolytic of choice is nifedipine. These are what the international guidelines say. But in India, the tocolytic of choice is nifedipine. Right? So if you simply get a question, tocolytic of choice in preterm labor, your answer is going to be nifedipine. If you get a question like this, that tocolytic of choice at less than 32 weeks, right, endomethacin. If you get a question that tocolytic of choice between 32 to 34 weeks, then nifedipine. Now, why is it that beyond 32 weeks we are saying that nifedipine is the tocolytic of choice? That is because if you are using endomethacin at more than equal to 32 weeks, what happens? Tell me, I have taught you this at so many places. So if you use endomethacin beyond 32 weeks of pregnancy, it can lead to premature closure of ductus arteriosus, and it can lead to oligohydramnios. Right? That is why endomethacin is never used beyond 32 weeks. The most important reason for it not being used beyond 32 weeks is because it leads to premature closure of ductus arteriosus. Oligohydramnios is a complication which is seen with endomethacin if endomethacin is being used for more than 48 hours. So if you are using endomethacin for more than equal to 48 hours, it leads to oligohydramnios. If you are using endomethacin at more than 32 weeks, it leads to premature closure of ductus arteriosus. Right? Now, coming to what are the second line tocolytics? The second line tocolytics are atosivan. I will be doing all the details with you just now. Magnesium sulfate, then beta-2 agonist like terbutaline, and nitric oxide donor like nitroglycerine. These are the second line tocolytics, right? An important point to note is progesterone is not a tocolytic. Right? So progesterone is not a tocolytic. As I told you, progesterone can prevent preterm birth, but it is not a tocolytic. Right? Now, a few details about all the tocolytics. I want you to make a table where we are going to write about the tocolytic, its dose, its maternal side effects, fetal side effects, and the contraindication of that particular tocolytic. Coming to nifedipine, it is the safest tocolytic. Number one important point. Number two, it is a calcium channel blocker. All of you know that, I don't need to tell you. As a tocolytic, the loading dose of nifedipine is 20 to 30 milligrams oral dose. And once you've given 20 to 30 milligrams orally nifedipine, then you are going to repeat nifedipine 10 to 20 milligrams every 3 to 8 hourly. And maximum you can give up till 180 milligrams per day. Right? So in your hospitals, you will see that whenever a patient of preterm labor comes to you, you are going to give her, initially we start with 20 milligrams and then after every 3 to 8 hourly, we give her 10 milligrams. Maximum you can go up till 180 milligrams per day. Now, what are the maternal side effects of nifedipine? Maternal side effects of nifedipine are it leads to vasodilatation, and because of this vasodilatation, there will be flushing, there will be headache, dizziness, hypotension. Right? So these are the maternal side effects of nifedipine. What are the fetal side effects of nifedipine? There are no significant fetal side effects of nifedipine, and that is why we say it's the safest tocolytic. What are the contraindications for nifedipine? The contraindications for nifedipine are number 1, hypotension, and number 2, heart failure with decreased ejection fraction. Right? So this is what you have to know about nifedipine. In India, this is the tocolytic of choice. Then comes the second tocolytic, which is endomethacin. What is endomethacin? How does endomethacin act? Endomethacin is a COX inhibitor. It is a non-specific COX inhibitor, and it is also an antiplatelet drug. Right, now when nifedipine is used when endomethacin is used as a tocolytic, the loading dose which you have to give is 50 to 100 milligrams orally, and then you are going to repeat every 4 to 6 hourly. You are going to give 25 milligrams every 4 to 6 hourly. Right? What are the maternal side effects of nifedipine? The maternal side effects of nifedipine are nausea, gastritis, GI reflex, gastroesophageal reflux, and then it may precipitate platelet dysfunction might happen. Platelet dysfunction. Right? What are the side effects of fetal side effects of nifedipine, of endomethacin? Just now I told you, endomethacin, if it is given at more than equal to 32 weeks, or if it is given for more than equal to 48 hours, it can lead to closure, premature closure of ductus arteriosus, number 1. And number 2, it can lead to oligohydramnios. The most common fetal complication which is associated when endomethacin is used for more than equal to 32 weeks at a gestational age of more than equal to 32 weeks is premature closure of ductus arteriosus, and the most common fetal complication which is seen if it is used for more than 48 hours is oligohydramnios. Right? Now, what are the contraindications for using endomethacin? The contraindications are if mother has a liver disease, if mother has kidney disease, if she has bleeding diastasis, right? And if she has a severe gastritis or ulcerative disease. Right? So these are the details which you need to know about endomethacin. Coming to the next tocolytic, which is a second line tocolytic, and that is beta-2 agonist. In beta-2 agonist, earlier retrodrine was also being used, and isoxsuprine was also being used as a tocolytic, but nowadays only one beta-2 agonist is being used as a tocolytic, and that is terbutaline. Rest all have been discontinued. So we do not use retrodrine or isoxsuprine these days as a tocolytic. Now, beta-2 agonists, they are not being preferred for use as tocolytics because they have a lot of maternal side effects. What are their maternal side effects? And I'm sure you know these much better than what I know. Most common side effect is tremors. Apart from this, it leads to palpitations. Then it leads to tachycardia, and that is why whenever you are using a terbutaline as a tocolytic, you should always monitor heart rate of the patient, and if heart rate goes more than equal to 120 per minute, then you should immediately stop it. Right? Then it leads to hyperglycemia. It leads to hypokalemia, and that is why in all patients in whom you are using terbutaline as a tocolytic, you should monitor their blood glucose levels and you should monitor their potassium levels every 4 to 6 hourly. right? Then rarely it may also lead to pulmonary edema and it may lead to myocardial infarctions, right? Now the fetal side effect, one of the fetal side effects is it can lead to neonatal hypoglycemia, but then that's not very significant, right? Then what are the contraindications for using beta-2 agonist? Contraindications are if number one, there is heart failure with tachycardia. Number two, in diabetic patients. Number three, if there is poorly controlled hyperthyroidism. Please remember it should be used with caution in pregnant females who have risk of bleeding. Right? For example, patients of placenta previa, right? So in this category of patients, beta-2 agonists, they should be used cautiously. Then coming to the next tocolytic, and the next tocolytic is atosiban. What is atosiban? Atosiban is an oxytocin vasopressin receptor antagonist, right? It is not FDA approved and it is not available worldwide. So it is not available in India also. Right? Now again, dose of atosiban that is not needed for you. Please remember that atosiban doesn't have any maternal side effects, it doesn't have any fetal side effect, and it doesn't have any contraindication. That is why it is the best tocolytic for heart disease patients, and that is what question comes to you. But then the problem is it is not available worldwide. Why it has not FDA approved? Because earlier the studies which were done in 2014, they showed that the effect of atosiban is not much and it led to increased fetal mortality. But then later on when studies were done, they showed that nothing of this sort happens. And that is why in a few countries atosiban is available, but then in some countries it is still not available, right? Then comes magnesium sulfate. Magnesium sulfate can also be used as a tocolytic, and when you are using magnesium sulfate as a tocolytic, the tocolytic effect comes when the magnesium sulfate concentration is 9 to 10 milliequivalents per liter. And all of you know that when magnesium concentration goes to as high as 9 to 10 milliequivalents per liter, then the side effects start appearing. And what are the maternal side effects which are going to appear? There will be diaphoresis, right? So there will be slurring of speech. There will be loss of deep tendon reflexes, right? Now, magnesium sulfate is not associated with any fetal side effects. What are the contraindications for using magnesium sulfate? The contraindications for using magnesium sulfate are myasthenia gravis, cardiac conduction defects, then renal failure, myocardial compromise or myocardial infarction, and please remember, you are never going to use calcium channel blockers and magnesium sulfate together because this can lead to respiratory depression. Right? Whenever you are using magnesium sulfate, what do you monitor? You always monitor the respiratory rate and you monitor deep tendon reflexes, right? And urine output. Clear to all of you? But then magnesium sulfate, although it can be used as a tocolytic, it is not used because the concentration of magnesium sulfate which is needed to bring about the tocolytic action is that concentration which can also bring about maternal side effects, right? Now, some important one-liners which they may ask you on tocolytics are, which is the safest tocolytic? Safest tocolytic is nifedipine. What is the drawback of endomethacin if it is used in a pregnant female with gestational age more than equal to 32 weeks? It can lead to closure of ductus arteriosus. What is the tocolytic of choice in heart disease patients? Atosiban. Which tocolytic is contraindicated in diabetic patients? It is beta-2 agonist. And what is the tocolytic of choice in diabetic patients? It will be the safest tocolytic, which is nifedipine. Right? So these are certain one-liners they may ask you on tocolytics. Right? Then, what are the absolute contraindications to tocolytics? So what are those conditions in which tocolytics as a category of drugs is not going to be used, right? So the absolute contraindication to tocolytics are, number one, if there is death of the fetus, intrauterine death of fetus, right? Number two, if there are, lethal anomaly of the fetus on ultrasound, or if you are getting fetal distress. So in all those conditions of the fetus where it is no use of prolonging the pregnancy, those are the conditions where tocolytics are contraindicated. For example, if there is intrauterine death of the fetus, right? So in intrauterine death of the fetus, are you going to give corticosteroids? No. If the fetus is dead, I'm not going to give corticosteroids. If I'm not going to give corticosteroids, am I going to give tocolytics? No. Number one. Number two, in lethal anomaly of the fetus on ultrasound. Now, if there is lethal anomaly of fetus on ultrasound, are you going to give corticosteroids? No. Because as such, once the baby will be born, there is going to be, this baby is not going to survive. So is there any use of giving corticosteroid? No. So if there is no use of giving corticosteroid, there is no use of giving tocolytic. Next is fetal distress. Now, if the baby is there, if there is fetal distress, are you going to prolong such pregnancy? Are you going to give them corticosteroids? Yes, I may give them corticosteroids, but then am I going to give them tocolytics so that the contractions stop? No. If there is fetal distress, I have to deliver this baby, right? So if there is fetal distress, even though I may be giving corticosteroids, but I'm not going to give them tocolytics because I have to deliver such a baby. Now, instead of writing fetal distress, in your options, it could be written as category 3 tracings. Category 3 tracing on CTG. Right? So whether they write category 3 tracing on CTG or whether they write fetal distress, it means one and the same thing. Right? In both these conditions, you have to immediately deliver the baby. And if you have to immediately deliver the baby, obviously you are not going to give tocolytics. Now, so these were the fetal conditions in which tocolytics are contraindicated. Now, tell me, in which condition was corticosteroid contraindicated? Corticosteroid was contraindicated if there was chorioamnionitis. And obviously, if you cannot give corticosteroid, you are not going to give tocolytics, because the only role of tocolytics, as I told you, is to buy time for corticosteroid to act. So in all those conditions where I cannot give corticosteroid, I'm not going to give tocolytics also. Right? Then I told next is, suppose if there is a mother's condition, if mother is hemodynamically unstable. If mother is hemodynamically unstable. So if mother is hemodynamically unstable, again I have to deliver such mothers quickly. I am not going to give her tocolytic and prolong the condition which is leading to her hemodynamic instability. Right? So if mother is hemodynamically unstable, I am not going to give her tocolytics. Right? Then the next condition in which you are not going to give tocolytic is if there is preterm labor which is happening at more than equal to 34 weeks. So preterm labor which is happening after 34 weeks, I am not going to give them tocolytics. Then suppose if preterm premature rupture of membranes is happening. What is preterm premature rupture of membranes? So preterm premature rupture of membranes is any membrane rupture which is happening at less than 37 weeks, right? So if preterm premature rupture of membranes is happening at less than 34 weeks. So ideally, whenever there is preterm labor at less than 34 weeks or there is preterm premature rupture of membranes at less than 34 weeks, you have to give tocolytics. Just now when we'll talk about preterm premature rupture of membranes, I'll tell you this, that management of preterm premature rupture of membranes at less than 34 weeks is you give them corticosteroids and you give them tocolytics for 48 hours. But if suppose there is preterm premature rupture of membranes which is happening at less than 34 weeks and there is unstable lie, so unstable lie leads to increased chances of cord prolapse. So in all those cases of preterm premature rupture of membranes, wherever there are increased chances of cord prolapse, the head of the baby has not yet engaged and there are increased chances of cord prolapse, in such cases also I am not going to give tocolytics. And one last relative contraindication is if the dilatation of the cervix has become more than equal to 3 centimeters. So if the dilatation of the cervix has gone more than equal to 3 centimeters, then I am not going to give them tocolytics, right? So these are all the conditions in which tocolytics are contraindicated as a group, right? So I was telling you that there are two problems with preterm labor. Number one is the lungs of the fetus are not mature. And then I told you that for maturity of lungs, you are going to give them corticosteroids. And if preterm labor is happening at less than 34 weeks, along with corticosteroids for 48 hours, you will have to give tocolytics. So we've done everything about corticosteroids. We've done everything about tocolytics. Now, I also told you that if preterm labor is happening, the second problem which could happen is that there are increased chances of cerebral palsy. And to prevent cerebral palsy from happening, you give them magnesium sulfate. So let's talk about magnesium sulfate for neuroprotection now. Now, magnesium sulfate, what does it do? It decreases the chances of cerebral palsy. When do you give magnesium sulfate? You give magnesium sulfate when preterm labor happens at less than 32 weeks. Please remember, it is less than 32 weeks, not 34 I'm saying here. Magnesium sulfate has to be given whenever preterm labor is happening at less than 32 weeks. What is the dose? You are going to give IV dose and the loading dose is 4 grams IV, which you have to give over 20 minutes. And then you have to give a maintenance dose of 1 gram per hour IV. Maintenance dose is 1 gram per hour IV. Maximum you have to give it for 24 hours. And obviously when you are using magnesium sulfate, you are going to monitor the respiratory rate, you are going to monitor the deep tendon reflexes. And the contraindications are the same which I told you as a tocolytic. What were the contraindications for using magnesium sulfate? Is that clear to all of you? Okay, now if that is clear to all of you, then let us see how am I going to manage preterm labor as a whole if preterm labor is happening at more than equal to 34 weeks or if preterm labor is happening at less than 34 weeks, right? So this is how you're going to get a question. Preterm labor at more than equal to 34 weeks or preterm labor at less than 34 weeks. Now, whenever a patient comes to you with preterm labor, whether she's coming to you at more than equal to 34 weeks or whether she's coming to you at less than 34 weeks, in both the cases you are going to admit the patient, and in both the cases you are going to observe the patient for dilatation and contractions. You are going to see whether the dilatation is increasing or whether the contractions are increasing or not, and this observation has to be done for at least 4 to 6 hours. Before that, I am not going to tell the patient to go home. I have to observe the patient for at least 4 to 6 hours. Third thing what I'm going to do is, in both these cases, I am going to give them group B streptococci prophylaxis. So whenever you have a patient of preterm labor, you have to take out the rectovaginal swab so that you can send it for culture, but simultaneously you are also going to give her prophylaxis for GBS. Why are we doing this? See, I am going to start GBS prophylaxis. Now the result of culture is going to come in 48 to 72 hours, right? So till 48 to 72 hours, I'm going to give her GBS prophylaxis. If suppose the culture comes out to be negative, I'm going to stop the antibiotic. If it comes out to be positive, I'll continue with the antibiotics, right? Now, then comes corticosteroid. What is the role of corticosteroid? The role of corticosteroid is it is going to accelerate the lung maturity. Now, as I told you, you have to give corticosteroid in both these category of patients, whether preterm labor is happening at less than 34 weeks, then also whether it is happening at more than equal to 34 weeks, then also you have to give corticosteroids. Then comes tocolytics. Now, what is the role of tocolytics? The role of tocolytics is to buy time for steroids to act. Now, if preterm labor is happening at more than equal to 34 weeks, we do not give tocolytics. If preterm labor is happening at less than 34 weeks, you are going to give tocolytics so that for how much time are you going to give tocolytics? For 48 hours, right? So that corticosteroids get time to act. Now, magnesium sulfate, what is the role of magnesium sulfate in preterm labor? As a neuroprotective agent. Now, as a neuroprotective agent, I'm not going to use it in preterm labor, which is happening at more than 34 weeks, but I'm going to use in preterm labor, which is happening at less than 32 weeks. Is that clear to all of you? Yes? Now, please remember, in established preterm labor cases, there is no role of progesterone, right? So once preterm labor is established, there is no role of progesterone and there is no role of induction of labor. There is no role of induction of labor. Clear to all of you? Now, all these patients, I am going to monitor them for 4 to 6 hours, right? And after 4 to 6 hours, if their contractions subside, right, and if there is no dilatation, I can send them home. Right? In all these patients, please remember, in all patients of preterm labor, you have to assess fetal membranes. As I told you, in examination, you have to be sure that the membranes are not ruptured. Because if membranes are ruptured along with preterm labor, then you are going to manage them as we manage premature rupture of membranes. And you have to be sure that there is no abruptio. Right? You have to be very sure of these two things, and you have to be sure that there is no fetal distress. So once you are sure that the membranes are not ruptured, once you are sure that there is no abruptio, once you are sure that there is no fetal distress and there is no contractions happening, dilatation has stopped, now you can send the patient back home. And you can also tell them, that they can keep on taking the corticosteroid. They can complete the course of corticosteroids at some nearby clinic. Clear to all of you? Yes? Now, I also need to tell you, before I end, we need to talk about Group B streptococci screening. So about Group B streptococci screening, there are so many things which I need to tell you. So let us talk about GBS screening. The first thing is, when should you do a GBS screening? GBS screening, it has to be done in all pregnant females between 36 weeks of pregnancy to 37 weeks plus 6 days. Right? So in all pregnant females between 36 weeks of pregnancy to 37 weeks plus 6 days, you have to screen them for Group B streptococci screening, and this has to be done by a rectovaginal swab. By a rectovaginal swab. Now, what is the method for screening? As I told you, it's a rectovaginal swab in which you have, when you are taking swab from vagina, you have to take it from lower vagina. You do not take the swab from higher vagina. You have to take it from the lower part of the vagina near the introitus. And the rectal swab should be taken 1 centimeter above the anal sphincter. Right? Now you can take either one swab or you can take 2 swabs. Right? And then you are going to put it in a media which is Stewart media at room temperature, and you are going to send it to the lab. This is how a swab for rectovaginal swab for GBS should be taken, right? So either you can take a single swab or you can take 2 swabs. One, if you are taking swab, when you are taking swab from vagina, it has to be from the lower vagina. And when you are taking swab from rectum, it has to be 1 centimeters above the anal sphincter. Right? Now, as I told you, all pregnant females between 36 weeks to 37 weeks plus 6 days, they should be screened for GBS. GBS screening should be done in all these females. Plus, GBS screening should be done in all pregnant females who undergo preterm labor. So all pregnant females in whom preterm labor is happening, in all these females, you have to do screening for Group B streptococci. Now, the exception to this rule is, there are 2 exceptions. Number 1, if a pregnant female has previous history of a neonate with Group B streptococci infection. Right? So if there is previous history of neonatal sepsis in the baby with Group B streptococci, then in such category of females, I am not going to do the screening. Why I am not going to do the screening? I'll tell you just now. And number 2, if pregnant female in this pregnancy has history of Group B streptococci bacteriuria, in this category of female, screening is not needed. Apart from that, all pregnant females who either go into preterm labor or in all pregnant females between 36 weeks of pregnancy to 37 weeks plus 6 days, you have to do a GBS screening. Right? Now, why am I saying that in these 2 females, in these 2 category of females, you don't have to do a screening? The reason is, in these 2 category of female, irrespective of the result of screening, I have to give them GBS prophylaxis. GBS prophylaxis has to be given. Right? So then there is no point in getting them screened. If I have to give a GBS prophylaxis, irrespective of what the result is coming, then why to screen in them? Clear? Then, Now, coming to the GBS Group B streptococci prophylaxis. Now, before I tell you what are the category of females in whom prophylaxis should be given, what you have to understand is that this GBS prophylaxis is being given to prevent the neonate from having sepsis. Right, so this GBS prophylaxis is not being given for the benefit of the mother. It is being given to prevent neonate from acquiring group B streptococci sepsis. Right? Then number 2, that is why this prophylaxis, it should be given intrapartum. Right? Now comes, what are the category of patients in whom you have to give GBS prophylaxis? So these are international guidelines, and please remember you have to know these international guidelines. You cannot say that this is being done in my hospital and you answer based on the what protocol is being followed in your hospital or in your medical colleges. You will have to give your answer based on the international guidelines. So international guidelines say that GBS prophylaxis should be given to all pregnant females in whom the GBS screening is positive. So the rectovaginal swab culture which was done, it showed that yes, there is GBS infection. In all those pregnant females, you have to do you have to give prophylaxis. Number 2, if there is a pregnant female in whom in this pregnancy she had GBS bacteriuria. As I told you, if a pregnant female in this pregnancy has GBS bacteriuria, I'm not going to do a screening, because irrespective of the screening, I have to give them prophylaxis, right? Or if pregnant female has previous history of a neonate affected by GBS, right? So if the pregnant female is giving you history of a neonate who earlier had sepsis because of group B streptococci. Now over here, how they can confuse you is they can say that there is a pregnant female who gives you previous history of GBS bacteriuria. She gives you history of GBS bacteriuria in previous pregnancy. Now in such females, you will have to do screening. Screening is not to be done only if GBS bacteriuria was present in this pregnancy. If in previous pregnancy she had GBS bacteriuria, you are going to do screening, and only if screening is positive, then you are going to give them prophylaxis, right? Then next condition is if there is unknown GBS status. Unknown GBS status and your patient has intrapartum fever more than 100.4. So if your patient is GBS status is not known and she is having running temperature of more than 100.4, then you are going to give her GBS prophylaxis. Number 1. Number 2, in all patients of preterm labor. All cases of preterm labor where we do not know about the status, I am going to give them GBS prophylaxis. Number 3, in cases of preterm premature rupture of membranes, when preterm premature rupture of membranes happens, and what is preterm premature rupture of membranes? It is rupture of membranes at less than 37 weeks, right? So in all patients of preterm premature rupture of membranes, in all preterm labor patients, I am going to give them GBS prophylaxis. Next is if there is a premature rupture of membranes. What is premature rupture of membranes? When membranes rupture at more than 37 weeks but before the onset of labor. So the rupture is happening at more than 37 weeks, but before the onset of labor. In such cases, if the rupture of membranes has happened for more than 18 hours, then you have to give GBS prophylaxis. In preterm premature rupture of membrane, in every case you have to give GBS prophylaxis. But in premature rupture of membranes, you have to give GBS prophylaxis only if membranes have been ruptured for more than 18 hours. Is that clear to all of you? Yes. Now, my next question to you is, what is the drug of choice for GBS prophylaxis? The drug of choice is penicillin G, which you give 5 million units loading initially as a loading dose or as an initial dose, and later after every 4 hourly you are going to give 2.5 million up till delivery. Right? That is the drug of choice for GBS prophylaxis. You can also give alternative is ampicillin, which is being used most commonly in India, where you are giving initially 2 grams IV, and then after every 4 hourly I will give her 1 gram IV up till delivery. Right? Now, if patient is allergic to penicillin, then I am going to give cefazolin injection, which again I am going to give 2 grams IV, and after every 8 hours I am going to give 1 gram IV. And in resistant cases, we are going to give vancomycin. Clear to all of you? Yes, so this is how you are going to manage preterm labor and everything what I needed to tell you about preterm labor and about group B prophylaxis and group B streptococci screening we have done in detail. Thank you so much.